So those are that's my disclosure slide and my disclaimer slide about language. So as Di mentioned, I'm Canadian. And so what are Canadians known for? We say sorry and a lot. We like hockey. We like beavers. We have a handsome, non-octogenarian prime minister for a little while longer. And for the people here in this audience, you know that we love our triple postnatal prophylaxis. That's one of the things that we're known for and derided for. We still like it. But what do we know about my opponent? So for those of you who grew up in the 80s, I did some sleuthing, Angela Lansbury. And so Dr. Musoke was profiled in The Lancet. No one's profiled me in The Lancet, but she was profiled in The Lancet on the occasion of her retirement from the university. And of course, she's a well-known investigator on seminal studies in this field, HivNet 012, HPTN 046, and PROMISE. But what else can we learn about her? And so in this profile, they asked her about her childhood. Did she always know she wanted to be a doctor? And she said, and her father was a famous pediatrician, I understand. And so she said, I had other ideas, like being a ballerina or an air hostess. But then she got a doctor's playset and realized that was what she was going to do with her life. But think about this. What are airline hostesses known for? They're known for their charm. And what are ballerinas known for? They're known for their grace. And so I would implore you, please do not be swayed by Dr. Musoke's charm and grace. Please be rational. Please listen to me, the tall, white Canadian male, and please follow the science. So why do we give postnatal prophylaxis to infants exposed to HIV? So I mentioned PACTG 076, the OG trial, one of the very first clinical trials showing a huge success in HIV science, where it showed a 2/3 reduction in transmission of HIV from mother to child with the use of zidovudine. Targeting the 3 potential time points of transmission during pregnancy, giving AZT alone, giving IV AZT during labor and delivery, and then giving postnatal prophylaxis to the infant for 6 weeks. Subsequently, HivNet 012, which my opponent was a lead investigator on, came out, and that compared maternal nevirapine single dose at onset of labor and then to the infant within 72 hours of birth versus zidovudine during labor and for 7 days afterwards. And again, this showed great success in terms of a halving of the risk of transmission to baby by week 14. And multiple subsequent studies have shown the benefits of not only single prophylaxis, but multiple combination postnatal prophylaxis when the mother is untreated. So one good example, HPTN 040, that showed that in the setting of untreated maternal HIV, postnatal combination infant prophylaxis was better than monotherapy. So a lot has happened, though, in the last 2+ decades in HIV, and all of these studies were done in women who were not suppressed during pregnancy. And subsequent trials, and increasingly we understand science through cohort studies, have demonstrated the greatest effect is from maternal combination antiretroviral treatment leading to viral suppression during the pregnancy. And that is the greatest determinant of risk to the infant in terms of transmission. And less so, and decreasingly so, the intrapartum AZT and infant postnatal prophylaxis components. I ask you, have there been any trials that demonstrate lower intrapartum transmission rate related to the infant prophylaxis component when a mother was taking suppressive ART leading into delivery? They don't exist. I've looked for them. If you find them, please email them to me, but I could not find them. Our French cohort studies have really contributed a lot to how we understand this field. And Briand et al. Showed that intrapartum IV AZT probably wasn't necessary. They found no transmissions with or without IV AZT when the maternal viral load was less than 400 close to delivery. Whereas if the viral load was greater than 1,000 and no IV AZT was given, postnatal prophylaxis did make a difference, and multi-agent postnatal prophylaxis was more effective than monotherapy. They also gave us the amazing study, which I quote every time I counsel a pregnant woman, that there was zero transmission risk among over 5,000 mother-infant pairs when the mother was optimally treated from preconception with an undetectable viral load at delivery. So we have to go back again. Why do we give postnatal prophylaxis now in 2024? We give it definitely for significant in utero exposure, if there's an acute infection in pregnancy or a later diagnosis in pregnancy where the viral load is elevated. Then we give many of us give triple antiretroviral prophylaxis or preemptive treatment in those scenarios for the benefits of early treatment. And we've documented what those will be. And then we also give it for viral exposure at delivery. And if there's an elevated viral load, then many of us, and increasingly guidelines are recommending that we should use 3 drugs as both prophylaxis and preemptive treatment. But if the mother's viral load is undetectable, we have to ask, is there a meaningful exposure to HIV? And what is the role of monoprophylaxis? U=U has changed the field and has improve the lives of people living with HIV in terms of reducing stigma. But what it's based on is strong evidence that says that for those who are fully suppressed on ART, genital tract exposures are non-infectious. And whether that's a sexual genital tract exposure or a birthing genital tract exposure, we are assuming that there is no virus there. And so if there's no virus there, what are we prophylaxing against? Over time, we've somewhat arbitrarily reduced our low-risk AZT postnatal prophylaxis durations from 6 weeks to 4 weeks to 2 weeks, mostly in the name of reducing toxicities. And so our hosts here in Germany published on this when they showed that reducing to 2 weeks of prophylaxis had the benefits of reduced hematologic toxicity without an increase in the risk of transmission. And our Swiss neighbors, I can say they're neighbors today, have also gone even further. So in 2016, postnatal infant prophylaxis was no longer recommended under the optimal scenario, and I had a great talk just before mine who went through what this looks like. But when the maternal viral load is less than 50, ideally throughout pregnancy, but at least in the last 2 consecutive measurements before birth, with an interval of 4 weeks, and the last one at least after it's 36 weeks, they no longer recommend postnatal prophylaxis. And the rationale for this was a lack of evidence of benefit or a need for postnatal prophylaxis in this optimal scenario, in keeping with U=U. And they had one very deep-cut reference that they gave, the Thai perinatal HIV prevention trial from 2000, which compared long and short maternal prophylaxis, either starting from 28 weeks or 36 weeks, and postnatal prophylaxis to the infant of either 3 days or 6 weeks. And basically what they showed was when the mother had the longer duration of treatment, that there was no difference between 6 weeks and 3 days. And then they editorialized, if there is a really relevant transmission risk, are 3 days of AZT truly effective? What do we have in the published sphere so far? So in 2019, they presented data from the first few years of this practice of no infant prophylaxis, and the first 87 children managed in this way had no transmissions. And now we're up to 2024, and thanks to Dr. Paolo Peoni, who I contacted, and he told me that since 2019, they've had about 30 cases per year, and putting it up to over 200 cases at this point with no transmissions. And so, yet again, the Swiss are leading the way. And so when we look at a risk-benefit analysis, what are the risks of giving prophylaxis versus not giving prophylaxis? So the risks are toxicity from AZT. We know about the hematologic suppression, anemia, neutropenia, and increasingly data that we have from Canada and other places, mitochondrial effects of NRTIs like AZT. There's also potential toxicity from nevirapine. Although it's usually well tolerated, it can cause hepatitis and rash. And then what about the long-term effects? We really don't understand the mechanisms for increased morbidity and mortality in children who are HIV exposed and uninfected. And are we adding on to this by using this, what the adult doctors call poison, or AZT in our newborn babies? And resistance, if the child is infected, resistance would be a concern if we're giving them postnatal prophylaxis with one drug. And all this for what benefit? The benefit, in my mind, after reading and positing on this, is that if mom actually has a detectable viral load, maybe that would be a benefit. But should we be doing this for all infants, just to benefit the small number where this might happen? And what about patient choice and autonomy from the mom's point of view? So, and if all of this hasn't convinced you, isn't the infant already loaded with ARV prophylaxis? We know that NNRTIs cross the placenta very well and persist in the infant for a long time. And we know that our core drugs that are used in the majority of pregnancies right now, the INSTIs, cross the placenta very well, preferentially with a cord blood to maternal ratio of 1.2 for dolutegravir. And that this persists in the infant for at least several days, up to 1 week according to Dolphin, and maybe even up to 2 weeks at levels that would be considered therapeutic. So we're already giving the baby prophylaxis by giving the mom her treatment. And so it brings us back to the question, who are we treating with infant prophylaxis? Are we treating the baby, or are we treating the doctor? Very, very homely baby. Let us be brave. Let us be rational. Please vote yes to no infant prophylaxis.